Okay, we're now live on Facebook. This is awesome. Hi, welcome. Welcome, Emily. Welcome, Cori. Welcome those of you who are watching on Facebook Live. This is very exciting, part of our Willow's Domestic Violence Awareness Month activities. We have been talking this month, over the course of the month, about domestic violence, not just as a private health issue, but also as a public health issue. And today, I've asked Cori and Emily to come and talk with us about not just the Willow and domestic violence, but also get into a little bit of territory of sexual assault and mental health services and how they intersect with emergency services, and sort of what the costs are of prevention versus education. Prevention and education versus crisis management, and how we can look at the kind of larger picture of domestic violence and mental health and wellness prevention as an alternative to crisis management through emergency services. So first of all, I want to say thank you for coming. This is an open forum, so if you have questions, we do ask that you leave them in the comment section. Facebook, I got my phone here, so I'm kind of keeping an eye on that. We will try to address questions throughout the course of the panel. We're looking at running from about 2 to 3 here, and so if you have any questions, we'll try to get those in sort of as they come through. I'd like to start, though, by giving everybody a chance to sort of introduce themselves before we get into the conversation. As I said, my name is Will Averill. I'm the Director of Communications at the Willow. I've been the Director of Communications since 2016. The time has flown. I'm going to be 4 years in December of working at the Willow. So that's very exciting. I have really found it to be quite a learning experience. I didn't come from a social services background. I came from a communications background. So it was a very steep curve learning about domestic violence and human trafficking. And I think that in some ways has been an advantage, because in my role as Director of Communications, a lot of what I do is kind of telling the story of our agency and telling the story of why our services are so important. And so learning those, kind of having those fresh and learning them is, I think, very helpful in terms of delivering that to people and coming at it from a perspective of someone who's interested but may not have a huge knowledge base. So this is what this is kind of aimed at today, is people who want to just know a little bit more about what we do and know about how we can look at these issues in the larger perspective. So that's me. I will. Emily, do you want to go next?
Sure. So I'm Emily Rhamy. Hey, everyone. I'm a social worker, and I am currently working at Bert Nash as the supervisor for the dialectical behavioral program. That's DBT, and also for the intensive outpatient program, which we usually call IOP. I've been in this position for, coming up on a year. And I also am a therapist at Bert Nash, right? I also provide therapy. My background, I have experience kind of working at a sexual assault center for a couple years, doing advocacy work. And I also worked in the public school system in special education for a while. So I've kind of been all over the place. And I guess I've also done some mental health crisis work.
Okay, great. Cori?
Yeah, so I'm Cori Green. I work at the hospital. I am the coordinator for the sexual assault nurse examiner program that we have here. We call it a SANE. That's the the short name for it, which sounds kind of counterintuitive, really, because are you sane to be doing this, right? But I have been doing this work since 2015, and I've been the coordinator for the past couple years. I've worked on medical units, I've been in oncology, I've done public health, but this is kind of where I've landed, and I probably enjoy this the most, to tell you the truth. And I've enjoyed the collaboration with the Domestic Violence Center and the Care Center and everybody involved on this panel. So thank you for having me.
Yeah, awesome. Well, I'm really happy to have someone here who kind of is in emergency services, because I feel like having a one-sided conversation with just some health and wellness organizations was going to give a little bit of a myopic view. So I'm glad that we can kind of have a more rounded viewpoint. I have always been fascinated by data and by information, and one thing that I have had has been a real challenge in the domestic violence arena is getting data. There's not a whole lot of studies done. There is not a whole lot of data that is out there. And so all of the statistics that we come with, several of them are from older studies, from studies that are like 2012, 2008. Getting new information can often be a challenge. And so we had the unique opportunity recently last spring to work with the KU engineering team in a program called the SELF program. And what it was is it provided us with a group of engineers that were supposed to do some sort of service project. Well, I didn't, think that we didn't really have any physical projects in the building that could be done, but we did have this kind of lack of data on our community and what these costs are with our community. So in speaking with them, we kind of came up with this plan for an information project rather than a kind of physical build project. So they helped put together a cost analysis of what prevention at the Willow costs versus what emergency services cost, using such emergency services as ambulance, court services, law enforcement, first response, fire department. It was very difficult because there aren't a lot of apples and oranges comparisons in the stats. Everybody kind of records the information differently, and I don't, like, the hospital records it one way. They keep track of the specific injuries, but not necessarily like what incident caused those injuries. The courts look at the cases and everything that is involved in those cases. Housing looks at people and families, rather than just individuals. So pulling information was tricky, but we were able to kind of come up with a general sort of idea that an incident consisting of these factors costs this much, versus an incident where shelter is used costs this much. And we put out a brochure. I'm just going to go ahead and share our screen for just a second. I'm not going to spend a huge amount of time on this, but if anybody is interested in sort of looking at this brochure, I'd be more than happy to share it with people. We made a whole bunch of them, and we're going to have it out soon. But this brochure kind of looks at domestic violence public cost breakdown for these different sort of Department of Children and Families, Fire Department, Police Department, medical, emergency technicians, hospital services, and the district attorney. And looking at those factors for 2018, 2018 and 2019, they were able to determine that the public health costs that we could relate to domestic violence were about in that $9 million range. We then looked at that versus the emergency services costs, the Willow Shelter Services costs, and we found that Willow Shelter Services were closer to $6,400 and $330. So the math worked out to be approximately $1 of prevention equaling $9 in emergency services, which is a huge difference, and something that I think if we could start to move towards a more prevention-based model, that we could continue to do more with less. So that's the topic, is to sort of take that idea of how can we look at this, what has traditionally been perceived as a kind of a personal, private family issue. And I think the same rules apply with the mental health cases and with sexual assault cases. What have traditionally been sort of individual criminal issues, and look at them as a larger public health issue, and how prevention and public health funding can help to alleviate using those crisis systems when they are often used instead of getting someone assistance. So that is the broader scope of kind of what I wanted to chat about today. First of all, does anybody have thoughts on that just off the bat before we go into some more specific questions? And it's okay if we want to just go into more specific questions. I'll check and see if we've got any questions from the crowd. At this point, we're still looking good. Everybody still seems to be with us here. Well, Emily, can we talk a little bit then about kind of the intersection? So domestic violence, we see the intersection happening when someone has when the cycle of abuse leads to a physical blow up, and there is some and the law enforcement is called. Oftentimes that also requires a trip to the ER. That also requires the involvement of courts or involvement of housing. But it's that blow up that does cause law enforcement initially in an emergency response to get involved. How does that work in sort of in the world of mental health?
Yeah. So, I mean, there's a couple things that this kind of has me thinking about. The first one is kind of like the intersection between trauma and mental illness, that folks who have been through a lot of trauma, which domestic violence would definitely fall into that category, right? Tend to have more difficulty with their mental health. And we certainly have a lot of folks coming to us for treatment who are in situations where there's violence going on in their home. Either directed at them or at someone else in the home. And so I think that there's a cost there as far as if you could prevent that trauma from happening in the first place, what would that person's mental health needs look like, right? So that's one end of it. And the other end of it is the folks who are in like a persistent pattern of abuse and their mental health is deteriorating, that could be something that could lead into a mental health crisis in itself, where you might have someone in the emergency room for a mental health related issue, being in that constant state of stress where your limbic system is firing and you're constantly in fight or flight is going to affect the way that your brain is structured. Right? That is going to cause your brain to build specific neuropathways to react to that kind of situation. And so I think it's no surprise that when someone is experiencing that fight or flight state all the time and they're having that chronic stress, that they are going to have an increase in depression and anxiety, and moods that they have difficulty controlling. And that being able to kind of partner with the Willows and with other agencies to help those folks kind of resolve some of that environmental strain on their mental health can really be a massive part about building a recovery system, right? So I think that kind of is sort of how our piece plays into it, where we can like prevent a lot of severe mental illness from being as severe if we could have people not in those stressful environments. Yeah.
Great. Well, and Cori, I think this then kind of leads into where we can't. We had a long conversation earlier about the expectations of like we can't expect ERs to do everything, but what services are they providing? What services can they provide? Where do they, when a crisis occurs, what are the challenges that staff face when it is something that's precipitated by a mental health incident or a domestic violence incident or a sexual assault incident?
That it's interesting when people talk about it being a crisis. I mean, that's what an emergency room is. It's just basically a crisis center. And so kind of peeling off and figuring out what someone is really there for can become difficult. And so what I mean by that is, like Emily was saying, they could be in a state of fight or flight. They could be in a state of depression. And so I don't come on board for, several hours because they aren't able to say, I was sexually assaulted, or I'm in a domestic situation because the crisis is what's happening, whether that's, pain or we're trying to figure that out, and it's just, we're not designed to really dive into sort of all the things that are leading up to that. We need to know at that moment how to save you and stabilize you, and then sort of put you where you need to go, because the idea is that you don't stay in the emergency room for days. It's supposed to be a stabilization type environment. And so it can be really challenging, because some people aren't in a safe enough space to be able to share what just happened. And so a lot of our challenges are really going to be around that, around getting people to understand that we have to create a space for people to be able to be safe enough to be able to come forward and say what's actually going on, and not just, oh, you have a broken wrist, let's fix it, let's get you home, let's get you out of here, we don't want you here. And on top of that, COVID is happening. And so I'm not saying we don't care, but it adds another challenge into your risks of being here. And so yeah, the crisis is a very difficult point to be in. And so when the emergency room is sort of involved in these types of cases, it can be really challenging to get to that information, if that's making sense. And so a lot of the work that we have to do, again, is just understanding that we've got to be better trauma informed. We've got to be better at approaching people, at asking them what's going on, because we have a lot of these questions we give people that are supposed to go, oh, that's a red flag, okay, they're not safe at home, or kind of thing. And we've done a really good job in the medical community identifying what these questions are and how we can capture these people, but is in terms of delivering those questions and really delivering that care, that training is not there. And that can't be expected of everybody. And so it's very challenging in talking about an emergency setting when it comes to domestic violence or sexual assault or even mental illness. It's very challenging.
And I think
it's interesting.
Oh, sorry. Go ahead. Go ahead, Emily.
No, I was just thinking about Cori, hearing you talk about it being like a hierarchy of needs, where you're looking at, what do we need to treat immediately in an emergency setting? What are the physical health things that need to be stabilized, and moving people along, and how that's very similar to the way we kind of address a mental health crisis too. If folks come to our access center at Bert Nash or come to the ER in mental health crisis, we're kind of looking immediately at what do we have going on that's life-threatening? What do we need to do to keep this person safe? And then we kind of go from there and work our way back, where it might kind of take a minute of assessing and building relationships and building trust with someone before you really get the whole picture of what's going on in their relationships and in their home. And then from there, even figuring out where they're at as far as what they're wanting to do next, what steps are helpful. So
yeah, and in our facility, we're so lucky, I think, to have a SANE program, because if you don't have time to spend with this patient and something's going on, you call us in and I can spend the whole day with them. I don't have other patients. And you have to remember too, if a heart attack is happening, that's going to take precedent over a broken foot. And so recognizing that they don't have time, or the skills, quite frankly, to dive into that sort of thing. And so we're very fortunate in this community to have a SANE program. And I don't think people understand that. There's a lot of things that I wish could happen for our program. There's a lot of things that I wish we could do more, but I recognize that we're just lucky in and of itself to be existing. There are so many hospitals that don't have this resource. And we've talked about in the past, Will, especially us, domestic violence and sexual assault and human trafficking, they all intersect with each other. And you can't just say one thing. Sometimes a patient is experiencing all of the above. And so we're just really fortunate in this community to have this program. I can't say that enough. but it's challenging and it's hard. And I wish it was a situation where you check in and say, this happened to me, and you get taken care of, but it just doesn't present that way. And again, when I look back at my career, it's like, once you meet that hierarchy of needs, once you reach that, that is when you can create a space for people to be able to feel comfortable enough, like, I am safe, I am okay. But that's a challenge too, because we've got to quickly get them out of here at the same time. They can't sit here all day. And so recognizing that we have this program, I think is something we should just be thankful for. And the fact that this hospital works so hard to keep it, which is really great. And so I might talk a little bit about, our challenges and our barriers, and I wish there was more, and all that, but at the same time, like, we've already reached the level of, being a program, which in and of itself is commendable to this community.
I want to take a slight step back and touch on something you said earlier when you were talking about trauma-informed care, because I think trauma-informed care is such a powerful tool in the arsenal, both of kind of emergency services and in the arsenal of for us and for Bert Nash as well. I think we all utilize trauma-informed care on a regular basis, but I don't think people are necessarily as familiar with what that it's one of those phrases that I think is used often but not really talked about what it is. So I just want to kind of lay out for folks, how does trauma-informed care sort of look in ER setting versus how does it look in mental health settings versus how does it look in advocacy? I'd love to kind of explore that for just a moment.
It's a little more challenging, in an emergency setting, because again, you might be extremely thirsty and extremely hungry, but we need to rule something out before you can have that drink. So some of the things we do are kind of counterintuitive to what trauma-informed care is. But, when you're trying to meet someone's, physical needs, emotional needs, and psychological needs all at the same time is the best way I can explain it. And that might mean a warm blanket. That might mean hold my hand. I can't tell you how many times I've turned my phone on a Pandora and stuck it on their pillow and said, keep it. During COVID in the very beginning, when you couldn't go in rooms, I've taken black markers and wrote, you wrote, "You matter" on the wall. There's things that you can do to just make somebody feel like they matter. And to me, that's the core of trauma-informed care. And really in the medical field, we don't get that training. That isn't something that, just because you're a nurse doesn't mean you automatically are what everybody thinks a nurse is, like a super caring, sensitive, person. And so we aren't given that training. That's something that has to come along in your career. And so that is something, Will, that we say a lot, but we don't follow up with, like, what does that actually mean? And I think that like I said, we've done so much research to be able to figure out the right things to say to people and how we can, fill out, how high risk are they of, for example, being suicidal. That's all great. And I'm glad we have those tools, but no one teaches us how to present those tools. No one teaches us how to speak to somebody in a way that's trauma informed. So it's challenging in an emergency setting to deliver trauma-informed care, because at the end of the day, like, we have to save your life, and that might feel not good. For example, being a forensic nurse and doing a rape kit, that's not the most comfortable thing for someone to go through. That in and of itself is traumatizing. And so you have to figure out a way to balance all of that, and it's really hard.
Yeah. Absolutely. And I think so much of it is, like you were saying, acknowledging, that, hey, this is hard and this is a hard thing to go through. I think in a mental health setting, sometimes we kind of get going and forget that it's really difficult for folks to come and ask for help. And that sometimes folks have mental health histories where there's been some trauma involved in seeking help, right? Either somebody didn't listen to what they were saying, didn't believe them, thought they were seeking attention, that kind of thing. And people come to us asking for help despite that and pushing through that shame and that fear. Um, and so I think to a certain extent, it's acknowledging that, of saying like, wow, you know what, you showed up here and you made it today and you came and asked, to talk about these things. And that's huge and so brave and so hard. Um, and kind of like validating that experience. And then also, just like you said, in mental health, it's about making them feel safe, creating a space where people feel comfortable and like it's appropriate to talk about their trauma. I think often people learn to not make other people uncomfortable, not upset people, not talk about what's going on for those reasons. And so part of what we do is just ask directly about what has happened to you in the past, what have you been through, and kind of leave that door open for them to disclose. And then also acknowledge the difficulty of disclosing, right? Of, wow, that was a hard thing to go through. It's a hard thing to think about. And I can tell right now how difficult it is for you to put words to it. And I think that the interaction between mental health and trauma is so huge. And without really thinking about the trauma bit, I could see how practitioners could get into a pattern of focusing on just the depression or just the anxiety, without recognizing the things that person has been through, to where, it's been adaptive for them to become that way. Right. In the work that I do, I work with a lot of folks with borderline personality disorder. And many of the people with that diagnosis have a lot of developmental trauma and have been through many years of abuse, or maybe they grew up in a home where they saw domestic violence happening regularly. And their ability to regulate their emotions has been greatly shaped by those experiences. And that's something that's helped them kind of survive that. So if we can kind of like go in and sit with them in that and say like, look, you've been through hell and you made it out. And like, I'm here to walk with you as we figure out how to let go of some of this pain and set it down. I think that that's a big part of what trauma-informed care looks like. But it becomes this really difficult many-year process, right, of building trust with someone and being there when they need you. Yeah.
I think there are definitely similarities of.
And I think sometimes
I think
sorry.
there's definitely similarities between both parts with how we work with trauma informed care as an agency in advocacy and in shelter, because obviously we looked at our systems before trauma informed care, and they were designed, it's group home living, so they were designed with a rule set of, this is what we need to do to all get by. We need to have this set of rules. And what invariably happens then is that you put the advocates in the position of the rule keepers. And so then the cycle of power and control that is the major reason that so many people, the major tactic of abusers in order to get control over their victims, is suddenly recreated in the shelter environment, accidentally, of course, but unfortunately, we start finding ourselves, kind of emulating those cycles of, you have to do this or you will be out. So with trauma-informed care, what we look to do instead is to look at those as adaptive behaviors rather than as problems that we need to fix, or things that they need to not do, and instead have kind of focus on conversations and focus on that relationship building and focus on having that safety, as opposed to relying on rules and a system of, if you do so many things, you're out. So I think it definitely, that underlying look at why is this behavior occurring, as the basis, rather than this behavior is wrong, or this behavior doesn't work, this behavior needs to be fixed. That's kind of the core thing that kind of goes through all three, I think, of those ways of using and adapting trauma-informed care to different situations. So I just wanted to kind of put that out there, to let people know, in case they didn't, kind of what the trauma-informed care process looks like as opposed to what was previously done.
Yeah. And I think that point about keeping an eye on where the power lies in the relationship as a professional too is so important, Will. And I imagine, Cori, in your work it is too, of making sure that you're kind of giving the person you're helping permission to set boundaries with you and to say no and to decide what happens. Yeah.
You know, I will say we also have a really good relationship with the sexual trauma and abuse care center, and an advocate comes to every single one of our cases. And honestly, like, that is powerful, because we're placing someone in the room that isn't working for me, isn't working for the hospital. And you know, what people don't realize, I feel like, when it comes to the medical world that I live in, you know, we're dealing with people on their absolute worst days, which means one bad reaction can spill into the community, and give people an idea of, oh, well, that's how that place works. And so, you know, a lot of times it's really hard to be dealing with people in their worst state at all times. And that's kind of how an emergency room runs. And so we're really lucky that the care center comes to us. Even during COVID, they've come, which has been really brave of them to do, because I know that can be really scary for people. And so we're really lucky. Like you said, I can kind of feel I don't have to do both jobs of advocate and the forensic piece. That doesn't mean they always come. Sometimes patients, it's their choice, right? But it is kind of worth talking about, you know, just in general, you know, the message that is sent to trafficked people and people in domestic violence situations and people that have been raped, that, you know, don't go to the hospital, don't trust them. Why would you trust them? And so, you know, we're fighting an uphill battle in terms of that, because one, you know, wrong experience that you had in a hospital can taint you for the rest of your life. And it could be explainable what happened. And, you know, I'm sorry you had that heart attack, and, you know, the things happen. And so it can be really challenging to be in this field and know that people don't trust you right off the get, right out the gate, you know? And so again, you have to like really work hard to create that environment. And a lot of times for me, it involves food, water, you know, clothes, warm blankets. I mean, I'll throw all that at them before I'll even, you know, dive into anything that has to do with the assault. So,
Yeah.
I just wanted to make that sort of point for the medical people.
I think that's interesting, and I want to touch on that, because I think this is where public health policy can help really push forward and help each other complement our services, and also help to move things to a more preventative model rather than a crisis model. And that is that there are programs that, you know, we are developing and we're working with, like having an advocate there and the same kit testing. Like having we've recently gotten a Jessica Gonzalez victims advocate with the Lawrence Police Department, who will go out to cases with officers and meet with survivors on site and be able to be there and give that information early. And I think in the same way that, you know, we, like, officers, domestic battery calls are some of the most dangerous calls that officers will take, because they never know quite what the situation that they're getting into is going to be. And we have been having this conversation kind of as a country about the role of the police in intervention and how that could be, how they are doing, you know, they are expected to do too much. A lot of the times they're expected to be mental health crisis counselors, victims advocates, everything. In the same way, I imagine that's a little bit similar to where we find ourselves in the ER. It's like, you know, there's one specific role, which is to make sure people are alive and you know, getting better and getting out on their feet. And then you know, to put on a bunch of different hats would then become confusing to them, I think, as well. So I'd just like to take a moment to kind of talk about those. You know, you talked a little bit about the Trauma Care Center and Sane Kits, and like for us, again, it's that Jessica Gonzalez victims advocate role, which is a new initiative to kind of work with officers to get that information out there. I think programs like these are where we can really start to help not just individual survivors on the worst days of their lives, but also alleviate crisis folks and first responders from some of the pressures that aren't necessarily their fortes that we can then help prevent. Is there anything similar to that, Emily, and sort of?
Yeah, absolutely. I mean, we do have right now a peer support program in the emergency room where we have folks who have been through a mental health recovery process, and they can go and basically, in the same way that Cori was talking about, sit with folks when they're going through a mental health crisis and kind of advocate for them and help them kind of walk that path if they don't really know where it's headed. And that can be a really important way to kind of loop them into our services and let them know what all we offer. We also have our access center at Bert Nash, where folks who are having a mental health crisis of any kind can come in and ask to speak to a clinician in that program. We have people that are available for crises all the time. And you can also call our direct number and speak with those folks. Right now, that's something that's offered at Bert Nash only during our business hours. But as we expand to the new crisis center, that's going to be increasing, where those services will be available more around the clock. We also have mental health trained responders, and we work with Lawrence Police Department to send responders out. And I do believe we are working to move towards having mobile crisis services where there will actually be a master's level mental health professional who could potentially go out and meet with someone at their home in a crisis, which will be a big difference for our community. And I think all of those things, you know, at times, these things all overlap so much. You know, like there are times where you'll find someone who is really struggling to want to stay alive and is possibly doing something to hurt themselves. And we have that sort of mental health crisis. Folks having increase in like psychosis symptoms, where maybe they're seeing and hearing things, and that's really scary for them. So we get those types of things. And we also have folks that have a lot of just chaos going on in their life. Maybe they just recently lost someone really close to them and they're really, really struggling with that. Maybe they are experiencing abuse and something has happened to them and they're not sure how to talk about it, and it's really affecting their ability to think straight, right? And we have all these different things that come together. And so a lot of those interventions are really just sitting with the person and helping them kind of get back into themselves and figure out how to put words to what's going on. And then we kind of go from there, whether that means kind of like reaching out to maybe the care center if they disclose some sexual abuse or trauma. Maybe it's reaching out to y'all at the Willows if they're not feeling safe in their home, or if they need help figuring out how to exit a relationship. We send folks to both of y'all to pretty often, and we'll even, you know, sit there in an appointment with someone in an office, and I've sat there while people call the care center for the first time or call the Willows for the first time, because it can be really scary for people to reach out and actually say, you know, this is part of my story and this is happening. And sometimes for folks, I think that's a moment where it becomes really real. And other times we have folks that aren't ready to do that yet, honestly, who are struggling with mental health stuff, and we can spend sometimes, you know, months or years in therapy with someone who's experiencing abuse, working with them on deciding when to exit that relationship and how to do that, and helping them find resources and helping them make those choices in their life, right? Because as scary as that can be as a therapist, to know that someone you care about very deeply, because us therapists very much care about our clients, but to kind of walk that with them as they move towards deciding to leave can be a big part of our work.
You know, another thing about trauma-informed care that we didn't really touch on is this idea of empowerment and this idea of collaboration. You know,
Yes.
we can kind of get stuck in our own little corners and say like, well, this is my role and that's your role. But, you know, recognizing that like we're in this role together and that collaboration can also save a person. And then by empowerment, I mean, you know, I've had a patient say to me before in follow-up, I follow up with people after a couple of weeks just to kind of, there's a lot of information we give them at a very critical time. And, you know, I've had someone tell me before that, you know, they had a plan to end their life. And then they came and had the exam and that plan changed. And so I think it's also okay to tell people that you're not broken. What happened to you is broken. You are not broken. And I think it's okay to tell people that this isn't something you have to suffer from for the rest of your life. This is okay. You can be an active member in the society. You can be an amazing person. You already are an amazing person. This is happening to you. So I think another piece of that was just making me think about it, listening to you talk, Emily, is that, you know, part of trauma-informed care is also being with each other in our services and recognizing we all have a role, and it's super important. And empowering patients, and I say patients, survivor, is okay. You don't have to have PTSD. This doesn't have to happen to you. And the way we respond can fix that. The way we respond to these things can be the difference. I had a patient that the doctor asked me to go sit with because she had been sexually assaulted in the past and she was really scared of a pelvic exam. And so he asked me if I would, you know, just go talk to them. And I basically, like I said, didn't really do anything. I just sat with them. And when it was time for the exam, I said, do you want me to stay? And they did. And we sat and talked through the whole exam. And she told me when it was over, she said, why weren't you the person that took care of me when I was raped? I feel like I'd be a different person. And it's like, I didn't do anything. It's just the way we respond is very important. And so that's the work we have to do in the medical field and in the emergency room is our response matters. The way the police respond matter. The way the EMS, it matters. And people do not have to be broken humans from being a survivor of domestic violence. They don't. Or of rape. They don't. It shouldn't be on them for the rest of their life. And we need to do the work to make sure they understand that.
Well, I'd like to close with just sort of one more quick question to everybody. We haven't really had any questions come through, so I'm assuming that we are so good, we are answering everybody. We're going through it. Rachel Louise Snyder, an author, the author of No Visible Bruises, which was the book that a book that we read in our management team meetings for the Willow about domestic violence, and an excellent resource if anyone is looking for an accessible book on DV, both as you know, just what it is and its effect on our society, both on the individual level and on the national level. She kind of mentioned that by the time we get to the shelters, by the time we get to the emergency rooms, by that point, it is already too late. And that what we need to do is set ourselves up so that we can avoid having those situations by working things so that the laws are more fair and just and reasonable, and people are aware of how to have these conversations and aware of what these issues of the power and control facets of domestic violence, of you know, a language and a communication and a dialogue about mental health that's more open and honest and reasonable, and open conversations about physical health and well-being. I just want to ask real briefly to kind of close. Are there any things that you each think, you know, either in your field or just in the field of public health, kind of broader changes that you would like to see, or an attitude maybe that if we could change this attitude on a national scale, it would be much more helpful and for us to view, you know, how can we talk about these issues as public health issues in a way that could change perceptions and help, you know, sort of alleviate the pressure on those emergency services by getting people what they needed sooner.
Yeah. I think that a big thing that we can do, the style of therapy that I practice is DBT, right? And we focus a lot on teaching people skills, teaching people ways to better control their emotions, recognizing what their emotions are, and then communicating them to other people in healthy ways, and also teaching people how to ask for what they want and set limits with people in a way that is healthy and productive and respectful. And I think that that's something that we have that's kind of missing in our culture a lot in the way we like raise children and deal with our own stuff, I guess. I think that if we could have more intentional like mental health prevention programs where we actually work with all kids and not just kids who are already struggling, but to teach them how to name their emotions, what their feelings feel like, and that it's okay um, to sometimes feel sad or feel angry and to share that with other people. Because what we know about emotions is that, you know, they kind of have a crest to them and then they go back down. And when we don't acknowledge our emotions, that crest goes higher, right? And when our emotions are repeatedly not acknowledged, our brain learns to make bigger and bigger emotional reactions, right? And so our environment kind of affects the way that our body produces emotions. And so if we look at an emotion like anger um, or fear, right? And those two happen a lot together. But if we could teach people at a younger age how to express their anger and their fear in ways that is healthy and safe, I think that we could really change a lot about what happens when they get into relationships later on, right? And then in addition to that, like just teaching people that it's okay for them to set limits and to speak up when something is happening that they're not okay with. And kind of encourage that more as a culture. So.
Thank you.
Yeah, agreed. You know, I think I don't know that I have a complete answer for you, except to say that, you know, we do a lot of work in our culture, talking to victims, talking to survivors, you know, studying them, trying to figure out what got them to that place. We don't hold offenders accountable. There's a common denominator in rape victims. There's a common denominator in domestic violence. It's called the assailant and the rapist.
Mm-hmm.
That is where the education needs to be. And
Yes.
I raised 2 kids in the public health system. There's not a lot of education on how to not rape another person. It's education on how to not get raped. And so we almost need to flip the script, so to speak, in this culture and do more work. And I'm sorry, I'm getting a little heated about it, but it frustrates me.
Fire it up.
I just got done at a meeting where people wanted to know the physical indicators of being able to see this. And it's like, I don't know why we spend so much time doing this. It's not on the victim for us to figure this out. And so, like you said, we should, all of us, be in the schools. There should be comprehensive sex education in every single school at every single level. And it shouldn't be aimed at preventing it from happening. It should be aimed at, this is how you not rape a person, and this is how you set values and goals in a relationship. And if you haven't been shown that, then where are they going to get that? They're going to get it at school. And so, you know, it's difficult for me to say exactly what we need, except that I get very exhausted with the constant talking about victims and survivors. Like, they matter. I'm not saying that. I'm saying I have been a SANE nurse since 2015, and I've been to court 1 time, and that was because she was charged with false reporting. I didn't go to defend a SANE kit. I went to defend a woman for having the right not to report her rape. So that, to me, is enough to say we aren't doing the right, we're not doing this right. Offenders are not being held accountable. For example, if you drug somebody, and rape them. A lot of times they come and they say, well, I don't want to tell the police. I don't even know really what happened. Well, how is that empowering that person? To me, it's the assailant going, well, they're never going to get anywhere because of this is how our culture looks. So it's almost like we have to flip the script in our culture. And I don't exactly know how to do that. I wish I had some sort of a formula, but it's tiring to me to spend so much time on victims and survivors when we should be on assailants and offenders and rapists.
I think that's an incredible point, and I would, from early on in my time with the Willow, I would consistently get the question at almost every tabling or speech, and it just regularly came up, and it was always this question: "It's why didn't she leave him?" And it's always phrased in a gendered way. It's always she and him, even though we know that the domestic violence happens to folks from all gender identities. But that question bothered me so much, and I finally, after talking to several incredibly wise folks throughout my time with the Willow, found the answer that I really like to give now, which is why did he think it was okay to beat her? And I get it's gendered, but they started the gendered conversation, so I'm going to go with it. We have to reframe these things, and linguistics are things. Changing the language and changing your way of talking about it, teaching how not to rape. Those things are quintessential in changing the way in which we are thinking about this problem, and I think are just as important as major public policy, such as, for domestic violence, limiting access to firearms for abusers, such as breaking down barriers by creating safe spaces for survivors, creating time off work, creating more lax rental laws for folks so they don't get stuck in a lease with an abuser. Anything we can do that way is fantastic, but I think that fundamentally, if we don't change the linguistic conversation, if we don't change the mindset to stop that victim blaming, we won't make any progress.
100%.
Yeah,
absolutely.
But that was
holding offenders accountable, and letting kids understand that not all men grow up to be rapists and abusers. That's not true. There's 100% amazing men on this planet, and so again, it's not going to get anywhere if you're finger pointing, and we it's almost like easy to be the assailant. We protect them with our laws and our policies, and we have to innocent until proven guilty, and all of that. But again, when you talked about getting into schools and starting young, it just made me think that that it's shifting a culture is work that we're all going to have to do together. It isn't going to be just one person or one entity. And so collaboration and empowering people to know that, like, if you've been in this experience, it's not the end of your life. It can be beginning in some ways, and not being afraid to tell people that.
Thank you both so much. I really appreciate it. I feel like, as I suspected, we could continue on for another hour. Time chatting with you, and hopefully we can get you back at some point to talk a little bit more. I'd love to learn more about your program, Emily, and Cori. I'd love to talk more about just sort of ways in which we can continue to shape that conversation. So we'll definitely have to do this again. But thank you so much. For those of you who are watching, thanks for joining us. If you do have questions, I will leave my email in the comments, and also for anybody watching the YouTube rebroadcast, I'll leave my email in the YouTube comment section, so you can just feel free to send us an email. But thank you so much for joining me today. I really appreciate it. Thanks, Emily.
Yeah, thanks for putting this together.
Yeah, thank you. All right,
okay, guys, have a great day.
You too.
Bye.